Please note, before starting, please note that this webinar will be recorded and will become available in YouTube. By joining this webinar, you automatically consent this recording. If you don't agree, please switch off your camera and do not speak. And now, good afternoon to all of you. And thanks for all to being here attending this webinar. It is a pleasure for me to be here again, presenting the second webinar related with Beamer project. For this webinar, we have the honor to have with us three speakers who have a lot of experience in working in medication adherence field. I would like to thank in advance their presence here to share their experience and expertise with us. To start, I have the pleasure to present Alpana Mair, which is head of effective prescribing and therapeutic division in Scottish government, and is also associate professor in Edinburgh, Napier University, and she will talk about adherence and inappropriate polypharmacy management. I must tell you that Alpana needs to leave the meeting early, so at the end of its presentation, we will be able to put her some questions. So, Alpana, thanks for being here, and the floor is yours.
Thank you, Alicio, for the introduction, and thank you to the Beamer project for inviting me to share the work that we've been doing, particularly around inappropriate polypharmacy and how that relates to adherence. I'm going to do this by taking a patient-centered or a person-centered approach and really talk you through how we have approached it in Scotland, but how we've transferred some of that work across to Europe, and give you a bit of a flavour of what we're trying to do, particularly with a focus on adherence and how we might improve the conversations in clinical practice. So I'm sure many of you have seen this data and are familiar with it. What we know is that we have an aging population, and all this is to be celebrated because we're managing conditions much better so that we have less mortality from long-term illness, but also in early life, we've been very good at public health measures to ensure that individuals are able to live longer. We know, however, though, that as people age, they don't necessarily live healthily. And what we want to do is to make sure that we minimize any harm from any agents such as medication that may impact on an individual's health. As an individual ages, they experience more long-term conditions, so they have more multimorbidities as we get older than a single disease. And that starts at a relatively early age. So you can see from 45, 64 people are already presenting with 2 long-term illnesses. What's really important is that we do take a person-centered approach. Now, if we looked at these 2 individuals, so this is this lady out in the park exercising, taking her daily activity, and we have this gentleman here who is basically sat on his couch for most of the day. If both of these individuals were to present with a heart attack or a stroke, both of these individuals would be managed exactly the same. But there would be little regard to thinking about what's important to the lady on the left and what do we need to do with the gentleman on the right. And we may need to manage the gentleman on the right intensively. And it's not to say that we won't manage the lady on the left, because we shouldn't take an age-centered approach. But it's about making sure that the medicines that they are given don't have an impact on their health so that they're not able to do day-to-day activities. So imagine if we added in medicines to manage the blood pressure here. What that might do is make this lady unsteady on her feet. She might not go out and therefore we might reduce the quality of her life. So we need to think about the consequences of prescribing. And using our judgment is really important when we take a person-centered approach. We know from many studies that as we get older, the number of medicines that people take increases, and there are many reasons behind that. At a younger age, it might be to manage acute conditions, but as we get older, as we've illustrated, it's to manage those long-term illnesses. But we also know that frailty has an impact, and the frailer you are, the more likely you are to be on more medicines. And ironically, it's these individuals that are more likely to have impaired renal or liver disease, and therefore their ability to metabolize and deal with the medicines may decline, and they may be therefore more prone to drug-related harm. So this is really a graphical representation showing you the number of people, and this is taking national data across Scotland. So this shows you the number of people nationally that are taking 5 or more medicines. And here, what's striking, what I find striking, is that actually you don't have to be too old in order to be taking 6 or more medicines. So this isn't 6 different tablets, this is 6 different preparations that you might take 2 or 3 times a day. So imagine the pill burden here and the impact that this might have on an individual's adherence. Now, it's important, and Alicia alluded to that in his introduction, that we focus on inappropriate polypharmacy. Polypharmacy in itself is not a bad thing. And for many, as we've already said, it's changed and it's improved outcomes for people so that they can live much longer. The issue that we need to deal with is when medicines are being given that there's no real evidence base for, or they're no longer needed. Maybe something's changed in the physiology, in the lifestyle, that means that a medicine that we prescribed before is no longer needed. And a common example here might be hypertensives as people get older. They may start to experience postural hypotension and we need to review it. Or it might be that the evidence base has changed and therefore it's no longer indicated. So that's the aspect that we want to focus in on. And the important thing about focusing in on the appropriateness of the medication is that we know from lots of literature that 50 to 80% of people taking 4 or more medicines don't take it as prescribed. Now, I know colleagues later are going to give you much more in-depth into adherence and the different stages, but just as an overview here, it's really important to remember that people are not always intentionally non-adherent. Sometimes it can be unintentional by an individual, or where it's intentional, it could be because they're experiencing side effects. So you can see from the photo here, a patient's tried to organize their medicines into a dosette to actually remind them to take them. But if you look very carefully, they've just decanted the medicines and then they're going to pick things out. Now, if you imagine if somebody else comes in and looks at this and picks this up, there is a potential to increase error and harm if somebody inadvertently gives somebody too many medications here. So non-adherence has consequences, as we know. It can have an impact on long-term illness and increases the risk of admissions to hospital and death, and is a huge economic cost to the individual, but also to employment and work and the economy. So it's important that it has a multifactorial impact when we think about patients being non-adherent with their medicine. And is polypill the answer? And I think that we know that we have the technology now that we can print polypills, but I think that the thing we have to get right first is that we have to make sure that the medicines are right for the individual. Then we address the adherence. If we do that, we make sure that the medicines we give an individual are not causing them any harm. So there is a place for the polypill. We have to make sure that the medicines are right for the individual first. why do we need to do that? Well, we know that unplanned admissions to hospital every year, 8.6 across Europe every year, due to medication-related harm. And 50% of these are due to adverse drug events that are preventable, with 70% of these being in people over the age of 65 or more. And you can see again here the huge economic cost in order to do that. So how we've addressed that is about taking a person-centered approach to review medication. And through this process, we encourage having conversations about adherence with the patient and their carers and their family. So the very first question is really, what matters to you? So what's important to them? So if you think about the two individuals I shared with you right at the beginning, what might be important to the older lady on the left, is that she's able to maintain her physical mobility, so that the medicines we give her don't have an adverse impact on that. So finding that out is really important. Then thinking about, is this the right medicine? Are we giving any unnecessary medicine? So this is picking up on the inappropriate polypharmacy. And if we do give a medicine, is it effective? And that might give us a clue to adherence, because actually if we're not getting the targets that we need, is there an underlying reason? Because we don't want to change dosages and adjust if really the cause is the patient's not taking it because they are worried or anxious about the medication. And for many patients, and depending on which healthcare system you're in, making sure that the medicine is cost effective is important. So if we monitor the effectiveness of medicines, at that point we can monitor if the medicines are doing any harm. That means that if they're causing side effects, which might mean an individual then stops taking the medicine, we can pick that up and we can have that conversation. And finally, coming right back to the patient, we need to agree and share the medication plan. So whilst adherence is really important to us as healthcare professionals, patients often tell us they don't like the word adherence. So they often like agree and share a plan, so that we can agree what we want to do in order to have adherence to the medicine, but to make patients and carers feel like they're part of the plan and deciding that with us. So I had a gentleman that came to my clinic. I work in a homeless practice, and this gentleman said to me, his breathing, he was going in and out of hospital because he wasn't taking his preventative treatment for his asthma. And I was asked to review this gentleman by the doctors in the practice. And when I asked him what was important to him, whilst I wanted to address the breathing, what he said to me, it's my pain that's really bothering me. Until I can sort my pain out and I can sleep well at night, I can't think about my breathing. Now, he just needed advice on how to take his medicines at the right time. He didn't need increase of his pain medication. But once we had done that, I could engage him in addressing his inhalers and how to get better control of his asthma. So it's really important that we sometimes think about that in the context of how we prioritize our actions with patients and families as well. So this is an app that we have that patients can access, and it's available globally, and there's an element in there for patients. So patients and carers can look up their medications if they want to know what they're for, and they can have decisions, be involved in decisions about whether they should take medicines or not. And this is important that the healthcare professional or prescriber does this at the point of prescribing. So patients and their carers can think about, what is the medication going to do for me? How is it going to help me? And so this will come up with these shared decision-making tools, and it will then give them information about the medication that you're thinking about, and set it out in terms of these Kate plots. And so the patient can be involved with the healthcare professional in making that decision. And if they're involved, they're more likely to take the medicines that we're going to prescribe for them. They can keep a list of their medicines as well. So as they may move in and out of hospital or to a care home, they can keep a track of, what does my medication list look like? What should I be taking? And they can just look that medication up and they can look up information if they want to know about it. So the other piece of work that we're doing is we know that it can be quite difficult to have conversations with patients, particularly about their adherence, if they can't see, if they can't visualize it. And this is some tools that we are developing so that using prescription data, national prescription data that's dispensed for an individual patient, we can then map out visually in a diagram like this when a patient collects prescriptions. So here you can see that the patient is collecting frequent prescriptions for their salbutamol, which is this purple line here. And then you can see that actually they've got gaps in their treatment for the beclomethasone. But in the middle here, you'll also notice frequent courses of oral steroids showing poor control of their asthma or their COPD. So when a patient says, yes, I'm collecting everything, I'm taking everything, it's a nice way to say, look, this is what I can see. What do you think? Why is it that we are seeing that you're needing frequent courses of your oral steroid, but you're not really using your inhaler? So this is work that we're doing in order to support that conversation so that the patients can be involved. And there'll be more information that's given like this to the patients, and it could be for a wide range of medicines, because we know, as I've already illustrated, patients are usually on 10 medicines easily when they have 2 long-term illnesses. So we've started, as I said, implementing this work and sharing this work across Europe. And what we're doing at the moment with a project called iSympathy, which is the next stage of sympathy, is implementing the program in 3 countries and looking at it at all ages and stages, because we know that multimorbidity is a problem. And so we're looking at it in Northern Ireland, Ireland, and Scotland. And the idea is to do these patient reviews across the 3 countries, 10,000 reviews, and taking a person-centered approach. And we've developed a medication appropriateness index with the author of Mair, so that we can take a person-centered approach to assess the appropriateness of treatment. We'll be collecting PROMs, and the important thing about collecting the PROMs is the PROMs ask the patient questions about their adherence. So that will be used alongside to help assess the benefits, but also the patient engagement around adherence with the medication. And again, we'll use all that information to do an economic assessment of the impact of the intervention, as well as seeing the reduction in medicines and hopefully the reduction in contact with healthcare professionals. So I hope that gives you a quick overview of the work that we're doing around how, by addressing inappropriate polypharmacy, looking at the medicines that might cause the most harm, undertaking a person-centered review, involving the patient, how that might encourage adherence, and particularly the use of the visual tools and the shared decision-making aids, so that the patients and their carers can be involved in their care in making the decisions about the medicines that they take. So thank you very much for listening, and I'm happy to take any questions.
Thanks a lot, Alpana. It's great. So, as I told in the beginning, Alpana needs to leave the meeting or the webinar early. So please, she is now available for some questions. I will start, and after I will give the floor to the other attendants. And so, Alpana, so polypharmacy, and particularly inappropriate polypharmacy, is a problem that has been identified a long time. So please let me, because you put here some questions, how we can address this problem? How, for instance, industry, or because you talk about polypills, this is the only solution for polypharmacy, or this inappropriate for polypharmacy, or you envisage, or you see other solutions for this. And to be honest with you, this question of polypharmacy is something that I listen in the last 20 years, but in fact, I don't see any kind of advances on it. So
yeah, so I think it's a really good question. So I think that I think a polypill is only the answer once you've addressed whether the medicines are appropriate or not. So I think that you have to do the medication reviews. So you need to assess the suitability of a medication for the individual. And I guess my like for pharmaceutical industries, it would be to think about the fact that often when patients take medicines, they're not just taking one medication, they're taking many. They don't often present with just one long-term illness, they'll have many. And it's the impact of that that we need to take into consideration when we're undertaking studies, so that we can see what is the impact when somebody's got to manage 6 or 7 different medications already, and then I'm going to add in another 4. Because I've had scenarios where patients will say, I don't want to take these many tablets. So how do you help them work out which are the ones that they really need in order to improve their outcomes? So I think that medication review is central, and that's the approach. I also think that we know already there's enough empirical literature that tells us which medicines cause the most harms. And some of those are unavoidable. So how do we, if we're going to add a medication in, and we know that these groups are going to be used, how does a new medicine have an impact on that? And it's collecting that kind of information that makes sure that we minimize the harm. We stop that 8.6 going into hospital each year across Europe. And when we stop those people experiencing medication-related harm, because all that will happen with adherence is patients will stop taking medicines if they feel unwell from taking a treatment.
thanks. So now a question, Eva, do you want?
Yes, thank you so much for your presentation. Very interesting things that you are developing. In addition to Beamer, I'm involved in another project which is called Gravitate Health, which works with regard to focusing information about medication. Your app was really, really interesting to see. Is there anything that, is this like a prototype, or does it really work already? Or is there something that you could share with us?
Yeah, so please just Google Polypharmacy Guidance. It's in the App Store. It's free for anybody to download. It is used globally, so you're welcome to access it. The only thing we don't have that I've talked to Alicia many times before is the translations. That's probably what we need, the translations, and to be able to use it in lots of different countries, because it's a tool that's there and available. And some countries have taken the guidance and translating it, but translating the app is a whole new ball game.
Yes.
So please feel free to access it. There's a patient section, there is a clinical section, and the idea at the moment is that we're updating it. So, but there's plenty of information on there, all the shared decision tools that you can use with your patients there. And it's also available on the web. So clinicians can use it in consultation, pull these tools up with patients and have those conversations.
Okay, many thanks.
Thank you.
Okay.
Laura?
Yes, hi. Thank you so much. Super interesting. So my question, I don't know, it was a question or a comment. When you were describing, the review with the patients, I was just thinking about my different experiences with clinicians in different countries. Right now I live in the US, and it's, at least here in Massachusetts, it's all very, it's collected. Like I have this app, and all my clinicians can see like what the prescription medications are and so on. But for example, when I lived in Germany, like there's no, I don't know whether it's changed, but there was like no central system. I could just decide to go to this doctor and they prescribe me something, and then go to this other doctor. And there's like, unless I just decide to go to my GP and tell them, oh, by the way, I went to see this person and now they've prescribed me that, no one would have any overview. So I'm wondering if you have any information or thoughts on what that means. Like, is the prerequisite for good management to have like this kind of, I don't know what's the right word, like centralized system? Yeah, I was just curious what your thoughts are.
Yeah, I mean, I think the system that you described sounds wonderful, that everything is in one place. And so, for example, in the UK, primary care is in one place, but it doesn't capture the record. If I go to my pharmacy and I buy something, it doesn't have that on there.
Right.
But we know that we can empower the patient. So, you know, you can be empowered to hold your own record, and that's what we've tried to do. So in the absence of having that complete record, to empower patients to actually hold their records, because the other thing is that we know that from, you know, what might be on a record might not actually be what the individual is taking. And we know that at transitions of care. So that's really important to do, is to try and match that up to. So ideal system would be right across and shared, something that a patient could contribute to, and clinicians could feedback. Certainly we're not there in the UK. But I think that I would agree that would be an ideal system where everybody could have access and see.
Right. Thank you.
You want to add?
Yes. Great presentation, Alpana. And it definitely resonates with me personally. Having one pill instead of multi pills to take is the best. And I agree that the starting point is a agreed treatment plan that meets the patient's requirements and needs. That is the starting point. If you have that wrong, then don't forget about adherence. My question, you're very much focusing on medication adherence. Do you also cover or attempt to cover the lifestyle changes that usually goes along with the treatment?
Yeah, so that's a good question. So the very first thing, by asking what's important to the individual, is to find out what else might they want to do, and before starting treatment, what else could be done. So one of the areas within the patient app, and the patients were heavily involved in developing that side of it, was to put information around lifestyle choices that they could make that might help them. So for example, when we've got guidance for diabetes, we might first want to think about diet and exercise first, which many people want to try first before they are prescribed a tablet to take. So there is information there. We don't track adherence to those plans apart from having conversations on those at review, but monitoring things such as weight or looking at smoking cessation, and those might be important things when we're looking about management of long-term conditions, but they're not tracked in the same way as the chart I showed you for the medications. Yeah,
because I definitely like that visualization. And one of the challenges we have in the BEMER project, since we extend our task to more than just medication, including anything that supports the treatment. And we are looking for ways to measure these different changes. Okay, thank you.
Yeah, no, thank you.
So, and finally, I don't know if I'm able to pronounce the name, Anupoma.
Hi.
Hi.
Yes, it's Anupama. I know it's a difficult name. Thank you for giving me the opportunity. Fantastic presentation. I want to go straight to 2 points here. May or may not be a question. One thing, in my experience, I have seen in that as a medical doctor, we are trained to think in a certain way. So if I take an example from my own life, for a condition, first one tablet was prescribed, which came with side effects. To manage the side effects, I was prescribed more pills. And then I ended up taking 11 different pills at the age of 40. My mother takes none, and she's younger and healthier than I am. It took me to a point where I felt that I have no reason to live like this anymore. I was so depressed and disappointed in myself. So from there, I felt that, we actually have to go to a more basic area where we intervene in the medical education, how we train our doctors to think when we are talking about management of certain conditions. So not just get up and write another one for a new symptom, because that new pill will come with another set of side effects. Yeah. And maybe think more in a holistic manner and try to go into the basic reason why this person is sick, may not necessarily require pills, maybe something else. So that's one, health education for doctors, management education for doctors, and also maybe health education and information for patients, because adherence sometimes come from a position where the patient really doesn't understand why he or she is instructed to do something and why not something else, For example, if a person doesn't know how the diabetes pills, metformin and all the other variations of metformin basically works and what does it do exactly inside the body, that person may not be very interested in diet and exercise, thinking, okay, I have a better, more expensive pill. It should make me better. Which it doesn't. It just makes you sicker and sicker and sicker, needing more and more medication. Yeah. So I think we can go back to education for doctors and patients. And for patients, especially in a very simple way, information should be explained. That could help. And secondly, it is touched upon by you and also other attendees here that information needs to be shared. Information needs to stay in a central place. And I think technologically it is very much possible, but politically we just cannot seem to agree. Technology has advanced, tremendously. We all have a citizen ID, right? Why not use citizen ID? It's just one ID, one number for buying and prescribing and all relevant matters, interactions with medication, using and buying. Then that one number can be used to store information at one place, and then we know what one patient is prescribed or using. And of course, across specialists, this may not be a big problem at certain countries, but in most countries, specialists do not talk to each other. They do not share information. And in my home country, they would sometimes hate to share information with other specialists, which is a very big problem. We keep on talking about multiple specialists working together for one patient, so patient-centered treatment protocol and all that. But then how do we get rid of this barrier first? And I think the ownership of data, all kind of medical data, has to remain with the patient. Maybe only then we can remove this barrier. So I wanted to ask you, do you look at this possibility of collecting data, so post-marketing, collecting data of prescribed medication in a centralized way where everybody can, put in their data, but the ownership remains with the patient as a solution, or even a, experiment maybe?
Yeah, so I think post-marketing surveillance data that's collecting centrally on the side effects and the harms of medication. I think what you're talking about is having a centralized record of all the interactions that an individual has. And I'm saying that we do it very well in one part of the health service, another part keeps their bit, but I think what we're working very hard on is about joining that up and about letting patients be at the center of that. And obviously one of the things the app does is it gives the patient the control of doing that. I mean, thank you for sharing your story. I could see that it was quite hard for you, and so I do appreciate that. But I think that's the problem that we're trying to resolve, is to resolve that inappropriate polypharmacy, because what we don't want is a pill for a side effect of one medicine and then another. But I think what you describe is a problem that many countries are grappling with, and how we resolve that, and possible solutions.
Yeah,
Okay.
right
Thanks.
now I live in a developed country, but trusting blindly my specialist did not help me at all. I had to become my own specialist.
Yeah.
So maybe sometimes we have to do that until we find a better solution.
Okay.
Thank you. Thank you for the time.
Thank you. So Alpana, thanks a lot for your speak. It was great. Okay, now we have Enrica Menditto, which is the director of the Center of Pharmacoeconomics and Drugs Utilization Research at University of Naples, Federico II in Italy, and she will talk about adherence levels in clinical practices as an indicator of quality of life, of care, sorry. So, Enrica, the floor is yours.
Thank you, Alicio. Thank you so much for your presentation, and thank you to the Beamer project for the invitation. And in my presentation today, I would like to talk about definition of adherence and its phases. During your practice, clinical practice or research practice, you have been confronted with several definitions of adherence, concordance, compliance, and in 2012, Ryan and colleagues published on the British Journal of Clinical Pharmacology the ABC taxonomy, a new taxonomy for describing and defining adherence to medication, which clarify the definition of adherence. The taxonomy describe medication adherence as a process. I think that is better. So, as a process, and medication adherence is described according to 3 operational quantifiable parameters: initiation, implementation, and discontinuation, which include persistence. If you are a clinician or if you are a researcher in better understanding medication adherence, the first thing to decide is what to measure. Initiation, what I'm interested in, initiation, implementation, or discontinuation. To clarify, let's have a look at initiation. How is defined initiation? Initiation marks the start of the treatment when the patient takes the first pill. Evidence from literature showed that about 20% of patients with a new prescription doesn't start their therapy. And maybe different reasons for patients to not start the therapy. I'm sure that from practice, from clinicians, there are several examples. Here, for example, a patient, a woman, 41 years old with rheumatoid arthritis. I didn't want to start, and I kept telling myself, I don't have arthritis, I'm too young. This is a clear example of a patient that doesn't want to accept to be sick. She refused the medication because she thinks that she's too young for starting the medication. And this can be one of the reasons to not start a therapy, but there are several reasons, and each motivation can have a different solution, but it is important to understand if the patient is at the beginning of the process, is at the beginning of the journey, or is already in the journey. Then after initiation, we have implementation. Implementation is defined from the taxonomy as the extent to which a patient's actual dosing corresponds to the prescribed dosing regimen, from initiation until the last dose is taken. Once the treatment initiated, patient may have barriers during the implementation phase. For example, we have here an example of a patient with hypertension that he has some problem to take the pill every day, every morning. So he finds a solution to set an alarm because he needs to associate to take the pill with an action. After the implementation, the last phase is the discontinuation. Discontinuation marks the end of therapy, when the next dose to be taken is omitted and no more doses are taken thereafter. And when a patient decides to stop a medication, maybe for different reasons, because he has some adverse effect, or because, as in this example, a patient with hypertension felt to have done everything he could with the hypertensive medication, and he stopped it because he thinks that there is nothing to do. And after discontinuation, the discontinuation marks so the end of the therapy. And a key element of the taxonomy defines persistence as the length of the time between initiation and the last dose, which immediately precedes discontinuation. So, according to the taxonomy, medication adherence is a dynamic process, a dynamic behavior, consisting of phases of initiation, of implementation, and discontinuation that vary over time, resulting in periods of persistence and period of non-persistence. So if you are interested in medication adherence, you have to understand in which phase your patient are, or what do you want to measure. And so the patient don't want to start taking medication, is a non-initiation. He has difficulties in taking medication. This can be intentional or unintentional difficulty to take medication. And this is a suboptimal implementation. And when a patient stops taking medication is discontinuation. So it's important to identify each of these phases and to evaluate the correct assessment method for the right measurement of each of these phases. So there are some barriers regarding a standard terminology. So it's very important when talking about medication adherence to use a standardized methodology, a terminology. So it's important to define the phases of medication adherence in order to be sure to measure at the same time in different situations and to be able to compare different situations and different behavior. But if we have a standard terminology, we need to have also standard of measurements. My colleague Caitriona in the next presentation will talk about the measure of medication adherence. In my presentation, I would like just to have a look from an health system point of view. In 2018, the OECD published a report to provide an overview of the current initiatives to improve medication adherence across the OECD countries, investigating the efficiency of health system, and from these reports, highlighted that routine medication adherence measures, as well as adherence-related quality and performance indicators, should be encouraged in order to improve health system effectiveness and efficiency. From this survey carried out some years ago, this is the picture that arose. And as you can see from this table, very few countries use some monitoring system of adherence at national or from an health system perspective. Only in this table we can see that only US and Norway and just few countries use DTI, stay for data and technology information. This country use some routine basis to measure adherence at system level. And from this point of view, the OECD report encourage all countries to adopt some system to measure adherence at system level and to develop some indicators to be able to monitor systematically adherence measures in different countries in order to compare level of adherence to medication and also to evaluate different interventions that are in each country and understand how to better improve the quality of care of patient. We discussed about this topic in a recent paper developed in the framework of the Partnership on Active and Healthy Aging, and we discussed how currently many countries have the opportunity to use data and infrastructure, ICT infrastructure, to build and create at system level a system able to monitor from prescription data or other data systematically the medication adherence. And one of indicator that could be developed in a very easily way is the monitoring of persistence. So if patients persist or non-persist for a long time in a treatment, this could be an easy way for a macro evaluation of how many patients are under treatment and stay in treatment for a long time. For sure, to be able to compare the indicator at different, between different countries and at different level, there are many challenges because it's important that this indicator can be comparable in order to be able to benchmark and compare the right measures among different countries. And some years ago, always in the framework of the Partnership on Active and Healthy Aging, we started this discussion about the comparison of data availability at different countries in order to identify some common data that are available in different countries in order to define some easy indicator able to be measured from different countries using comparable data and start to add to the indicators that are usually used to evaluate the market of medication that are just related to the volumes that are used and the cost of the medication. Also some indicators related to the quality of use of medication, like, for example, adherence. But to build up this system, the first thing is to standardize measure and to and to be able to compare and benchmark the same issue. So adherence is a dynamic process and resulting in periods of persistence and non-persistence. Monitoring and reporting persistence as a performance indicator could help in improving the efficiency of our system. And it's important that all these actions are included in the policy agenda, because most of time these actions are related to other parts of the quality of care, but there isn't a specific topic on the policy agenda that is related to medication adherence as a process of the quality of care of patients. I thank you for your attention. Very quickly presentation in order to be able to have more time to discuss about this topic. Thank you so much.
Thanks a lot, Enrica. We will do the discussion in the hand of the discussion of the presentation of Caitriona. So now we go ahead and we have with us Caitriona Cahir, which is a lecturer and research in Data Science Center at the School of Population Health Science in the Royal College of Surgeons in Ireland, and she's going to talk about the standard measures of patient adherence. So, Caitriona, the floor is yours.
Hello, everyone, and I'm delighted to be here today. You're all very welcome. So, just going to follow on from Enrica's presentation, and just to bring us back again to the report that she presented. And as she has highlighted, we know that adherence is a key component of quality of care for diseases. However, as she's just highlighted, very few countries actually routinely measure or report adherence as a quality performance indicator or as a type of performance measure at the health system level. And one of the kind of possible reasons for this is the lack of standard adherence measures. So how do we develop standard measures of medication adherence? Well, firstly, we need to determine what exactly we are measuring. Secondly, we need to know how it can be measured. And thirdly, we need to assess the scientific robustness of the measure. So what exactly are we measuring when it comes to adherence? As Enrica has just described, the European ABC project has proposed a new taxonomy of adherence, and it consists of 3 essential components, as she has highlighted: our initiation, our implementation, and our discontinuation. So how can it actually be measured? So if we go back to Osterberg's seminal paper on adherence to medication in the New England Journal of Medicine, he divides measures of adherence into subjective measures and more objective methods. So in terms of subjective methods, we have our patient self-report as the most common measure. It's simple, it's inexpensive, and it's a practical way of assessing adherence. More objective measures of adherence include things like your drug concentrations or your biological markers in the blood, tablet counts, direct observation of people taking their medication. You have your MENS, your medication event monitoring systems. You have your prescription and administration records, and also you have assessing the therapeutic effects or physiological markers. Essentially, to date, there is no gold standard measure of adherence, and each of these methods has advantages and disadvantages. And a combination of assessment methods is generally preferred to measure adherence in practice. But for the purpose of today's webinar, I'm going to focus on measuring adherence using prescription or administrative databases. So large-scale administrative databases, such as things as pharmacy claims data, patients' health records, and health insurance claims data, they provide a kind of a non-invasive, objective, and a relatively inexpensive method to measure adherence at the population level in real-world settings. However, to date, the lack of uniform and accepted standards of adherence measurement for big data is still very lacking. Our other problem is the structure and content of administrative databases can vary across countries and also within countries. And there are also a lot of non-trivial data operations and manipulation is required prior to any type of measurement of adherence. So we also have challenges in terms of data governance, access to data, sharing data, and also there's ethical, legal, and storage issues as well. So aside from these challenges, how components of adherence, of the adherence taxonomy using administrative or pharmacy claims data? So initiation is the first component in the taxonomy and the first step to understanding why patients do not take their prescribed medications. In order to measure initiation, the prescribing and dispensing events need to be assessed together, but there's often a lack of necessary data linkage between what is prescribed by a doctor and what is dispensed by a pharmacist on a large scale, outside of a small number of integrated health systems. There have been studies undertaken in Spain in a cohort of 1.6 million and also in a national population-based study in Poland. The second component of our taxonomy is the implementation component. And this is often estimated by calculating a type of summary statistic or a continuous outcome. Metrics such as proportion of days covered, your PDC, and your medication possession rate ratio, your MPR, are frequently used to summarize overall adherence as the percentage of a treatment regime that a patient has likely taken as prescribed based on the number of days that medication was dispensed during a specified time period. For example, this could be 50% or 80%. When this ratio is calculated across multiple refills, it is sometimes called the continuous measure of adherence, or you'll see it called as a CMA. Implementation is often also measured as a categorical outcome, with ratios above a specified threshold denoting adherence. However, how do we actually determine what this threshold should be to differentiate, for example, between good adherence, suboptimal adherence, and poor adherence? Many studies consider 80% to be the threshold, and whereas other studies consider 95% to be the threshold, as in cases of HIV. In fact, a recent systematic review by the International Society for Pharmacoeconomics and Outcomes Research investigated medication adherence thresholds in relation to clinical outcomes and found the included studies to be highly heterogeneous and could not confirm or reject the validity of this historical 80% cutoff threshold for adherence. The third component of the taxonomy, the discontinuation component, usually represents the time from the initial filling of the prescription until the patient discontinues filling a prescription. One method includes a simple count of days from the index prescription to the date of the final dispensing. Another is the estimated level of persistence, and this calculation allows the researcher to determine the percentage of individuals remaining on therapy at a given time. The final method is to quantify the gaps between prescription refills, and each individual has a certain grace period to obtain an additional refill, and if a patient's refill gap exceeds the predetermined grace period, that patient is considered to have discontinued treatment. Again, unfortunately, in the research lacks a uniform definition for the appropriate length of this permissible gap. And you'll often see this ranging from 15 to 120 days. So what about the scientific robustness of current standard measures of adherence? We need methods that are both reliable and valid. So reliability refers to the overall consistency of a measure. Does it produce the same results across time, individuals, and contexts? While validity refers to the extent to which a measure actually assesses what it is intended to assess. Ideally, we also want measures that give immediate results, are usable over a prolonged period of time, are acceptable or safe, and preferably are also practical and cheap and applicable to a wide variety of treatments. So what about the reliability of current adherence measures? A study of adherence to cardiovascular disease preventive medications found different mean adherence rates and proportions of adherent patients when using the NPR versus PDC. Hess and al. Applied 11 different adherence calculation methods, which were all some type of variation of NPR and PDC to the same set of pharmacy claims data. And they obtained adherence rates which ranged from 63% to 104%. Our own research group in RCSI undertook a study of patient-related factors, socioeconomic factors, condition-related factors, and therapy-related factors associated with medication non-adherence, based on the WHO model of non-adherence and the necessity concerns framework. And our study found that different factors were associated with non-adherence depending on whether adherence was measured as a continuous NPR or a categorical variable using a cutoff of 80%. So measures of adherence would also have a causal association with health and economic outcomes. A systematic review and meta-analysis synthesizing the evidence related to medication non-adherence and health outcomes in older populations by our own research group found that low medication adherence or suboptimal implementation adherence was significantly associated with long-term mortality in a fixed effects model and all-cause hospitalization. However, we found that despite a relatively large evidence base of 66 studies, meta-analysis was only feasible for 3 health outcomes and included only a small number of studies, 11 in total. While a systematic review at the economic impact of medication non-adherence across multiple diseases included 79 studies and found the annual adjusted disease-specific economic cost of non-adherence per person to range from $949 to $44,190 in 2015. This review also cited the wide variation in adherence measurement and study methodologies as a barrier to meta-analysis, making the comparison among studies very challenging and an accurate estimation of the true magnitude of the cost of non-adherence impossible. Both reviews have requested for more concerted action to establish and standardized methods of measuring adherence which are comparable across studies. So at this point, we seem to identify more problems than solutions when it comes to standard measures of adherence. It appears that there is a range of methods, a large range of methods, and a lack of transparency and standardization regarding the authorization of adherence measures. This complicates the comparisons of adherence results across studies and translation to real-world practice. However, some progress has been made. The ISPOR Medication Adherence and Persistence Special Interest Group has produced recommendations for assessment of initiation adherence and a checklist for medication adherence studies across administrative databases. Emerge, an initiative taken by the working group of members of ESPACOM, has developed guidelines based on adherence on the adherence taxonomy for reporting quantitative studies of medication adherence. And there has also been a study by Arnett and al. Who have proposed a harmonization of standards as well as definitions of measures and their operationalization in line with the adherence taxonomy as well to quantify adherence from administrative records. Some progress has also been made in terms of undertaking comparative population-based research. As Enrica has just described under the umbrella of Action Group A1 on prescription and adherence to medical plans, the European Innovative Partnership on Active and Healthy Aging, they undertook a collection of the characteristics of databases to build consensus on the use of common elements and measures to facilitate data sharing for measuring adherence. A feasibility study of performing a collaborative cross-country comparison of medication adherence has also been undertaken. And this feasibility study compared adherence rates in 3 highly prevalent chronic conditions across 3 different European cohorts based on pooled outpatient pharmacy claims data. A common protocol was developed, a minimum data set containing a list of standardization was developed, and a standard operation procedure for measuring adherence. And as we can see in these figures, the rates of implementation adherence were not the same across the 3 cohorts. Perhaps there may also be some benefit to simplifying things. Rather than trying to standardize the measurement of the specific components of the taxonomy, we should see adherence as a dynamic behavior consisting of initiation, implementation, and discontinuation phases of treatment that vary over time. The emphasis being on the fact that adherence is in fact a behavior. And like any behavior, it will vary, and there will be stages of adherence and non-adherence with the patient's medication taking behavior, influenced by multiple factors related to socioeconomics or healthcare systems, diseases, treatments, and regimes, and also to take into account patients' health and medication beliefs and motivation. Indeed, in recent years, we have seen a growth in the use of group-based trajectory modeling in measuring adherence in research. And this methodology has shown that participants can have very different patterns of medication taking behavior during a short period of time, including those who consistently have treatment gaps and those with initial poor adherence that improves over time. A study of older community dwelling patients with multimorbidity by our own research group identified 5 adherence groups: initial low adherers with a gradual increase, high adherers with a sharp decline, steady adherers with a gradual decline, and consistently high adherers and consistently non-adherers. Higher average adherence was also associated with a significant increase in utility or EQ5D utility. And group 5, which was our consistent non-adherers, was associated with significantly increased vulnerability compared to group 4, which was our high adherers. A recent systematic review of medication adherence trajectories identified 4 to 6 trajectory groups that describe longitudinal medication adherence behaviors. The most commonly identified groups were A, which was consistently high adherence, B, declining adherence, and C, early and consistent non-adherence, and D, initial non-adherence followed by an increase. The review also found that several predictors, including socioeconomic status, diseases, and therapy initiation, were routinely associated with group membership. Group-based trajectory modeling also allows for the identification of patients following a specific trajectory who may benefit from adherence support or an intervention. And it has already been used to develop a tailored motivational interviewing system based on these trajectories. However, it does require further research and testing. A common obstacle faced by researchers when using this methodology is deciding on the number of trajectory groups that may exist within a population. And this decision-making can introduce subjectivity, and there's no gold standard for model selection criteria. To date, also, the majority of adherence measurements have focused on single drugs or single diseases. Well, as we're all aware, as highlighted by Alpana, that multimorbidity has increased rapidly in recent times, affecting more than 60% of people aged 65 years or older. Standard measures of adherence in administrative databases used to evaluate single medication adherence are not necessarily valid for the assessment of adherence to multiple medications. Individuals within a cohort in Spain were found to vary considerably in their adherence to various drug classes, ranging from 72.4% for anti-diabetic medication to 44.3% for lipid-lowering drugs. In Ireland, we found that on average 20 to 40% of patients with multimorbidity were non-adherent across all conditions. We also found an inverted U-shaped relationship between the mean MPR and the number of morbidities, with the mean MPR for the cohort gradually increasing with the number of morbidities and then decreasing. A systematic review by ISPR, which set out to identify and characterize the multiple medication adherence methods used in the literature, concluded that there appears to be no standardized method to measure multiple medication adherence. The majority of studies seem to use some variant of the MPR or the PDC, rendering comparison of studies a challenge. And ISPR has proposed that a simulation or other follow-up studies need to be conducted to assess the existing measures in the terms of their ability to measure true multiple medication adherence. Standard measures of adherence need to take into account the prescription of multiple drugs from different classes and switching between classes of medications as well. One potential method is the daily polypharmacy possession ratio, which estimates the proportion of time a patient has medication available for use by considering the presence or absence of multiple medications on each day in the observation period. However, further research is needed to confirm the validity of this index. ISPR's review also highlighted the need to develop a checklist or guidelines with regard to the minimum reporting criteria involving multiple medication adherence studies. So to conclude, routinely collected prescribing and dispensing data, electronic health records, and health insurance claims data all provide us with an opportunity to develop and operationalize standard measures of adherence. The rising use of mHealth by patients for self-monitoring and disease management was also another potential source for data analysis. We need to develop standard measures of adherence that tell us the prevalence of adherence, consider the drivers or factors related to adherence, and the consequences of non-adherence. These measures need to be consistent, reliable, and valid. An integration of databases is also necessary to provide information on the clinical indication for medications and reasons for changes or cessation, as well as clinical and health outcomes. Patient self-report measures of adherence would also be integrated into administrative databases where feasible. This will enable the comparisons of adherence rates across disease groups, populations, and country, and allow us to evaluate adherence targeting interventions. Thank you.
Thank you so much, Caitriona, for this excellent presentation and useful. So, can I, please, we will give the floor for some questions. Ad, can you start?
I switched off my microphone. Sorry about that. Two great presentations, thank you. As you may or may not know, I'm part of the Beamer project, and I have 3 questions for you. The first, if you go back to the ABC taxonomy, where we talk about initiation, implementation, discontinuation, I believe, Enrica, you said that monitoring of persistence is key in this, and that started implementation. But if someone does not initiate the treatment, isn't that the first sign of non-adherence? And is that also, could that also be intentional or unintentional? That's my first question. Then if we go back to the measurements, and that's for Caitriona, where we said that we look at the prescription and the dispensing, but it doesn't say a lot about actual medication intake. Should we not include blood values in there? That's 2. And then if adherence is behavior, and behavior is dynamic, then how do you look at support? Because what I see is if adherence changes over time and is influenced as behavior is, then we need to measure that regularly and align our interventions to that. Do you agree with that? Those are the 3 questions.
Eric?
Yeah. Thank you so much, Ad, for your great questions. And these are the questions in measurement of medication adherence. First of all, I would like to clarify that first of all, we have to define which is the perspective of the measurement. Because there are different approaches depending on the level of the measurement. if we are talking about measurement of adherence in daily clinical practice from the patient or from the clinician or from the pharmacist, is it true that persistence can't be the right indicator to measure? But if our perspective is from the health, the system, and we want to have once a year, twice a year, a macro picture about how things are going on in different therapeutic classic, in the use of some type of drugs, in the use of some specific medication, for example, at macro level, for example, how things are going with the use of, with the chronic use of medication for cardiovascular, what is the level of persistence in therapy at 1 year? This is an information at macro level that is able to give us an information about on how things are going at system level in the market of the medication, about the chronic use of medication. In this case, persistence could be an indicators that can give us this type of information. Is it true that if we want to measure at a different level, medication adherence is not the right indicator? But and we have to use some device that are able to help us to understand how things are going on. And but the perspective is different. So I think that it's very important to define which is the perspective. As we think that it's we know that is a multidimensional process, and we can measure different phases of adherence at different level. So we can have indicators, that are useful, but it depends from the perspective and from the objective that we have, which kind of information we want to reach. The proposal to use persistence as an indicator of measurement of adherence is with the aim to perform an analysis at the system level about the use of chronic medication in short, medium, long term.
Okay, thank you.
I hope that and for sure we need a different device and different. It's true. We have to find a solution that is not the perfect solution, as it's not possible to have the best response to all these questions. But I think that we have to find the best compromise to find a solution for each type of objective that we have in the evaluation of the quality of care at system, at clinician, pharmacist, patient, and patient level.
Okay. Yeah, that's actually the reason behind my questions. I'm not really looking for a solution, just an improvement of the present situation. And if I think about changing the system, that will take years and millions of people to convince. So we try to focus more on a micro level, improving it from a patient perspective and an ACP perspective, because they are in that agreement together. So I was looking for, okay, what could help them? Is there something we can add to the mix you already have?
Caitriona, do you want to add something, or we go to the
Yeah,
next
no,
question?
exactly. It is the perspective, and I think when you're trying to, particularly when it comes to initiation, it is when you're trying to measure that at the macro level, you're really looking for linked integrated healthcare systems where what the doctor prescribes can be linked to what the pharmacist dispensed, and and there's very not a huge amount of that at present, but it's as Enrica described, is coming up with a method that tries to capture as much of the picture of medication taking behavior, at a population level, and to capture those phases as one unit, initiation and implementation and discontinuation together. And there's always going to be that problem with when you're looking at, particularly if you're measuring at a population level using administrative databases, is that we've no idea if actually patients have taken the medication or not, which in practice, or any healthcare professional will have, whether it's just with something dispensed doesn't mean they actually consume it properly or take it properly as prescribed. Hopefully at some point, by focusing on the patient level and also the population level, by improving patient adherence by healthcare professionals, that'll feed into more accurate population level adherence rates as well over time.
Yeah, that's what we try to achieve with the BEMER project, focusing on the micro level, if you will, because if you cannot prove change improvement on a lower level, then there's no way you can take it to the next level.
Mm-hmm.
Thank you.
Thank you. Let's move. Anupama, please.
Thank you.
Try to be short because we don't have a lot of time.
It seems we agree on the same points. My first question was actually, how do we prove intake? Because all the other measures are quite indirect. And the second question is related to what Caitriona was pointing at about outcomes and clinical outcomes, whether it was intaken or not by about the medication. So my question specifically is, what do all the presenters think about using smart devices, wearables on your body, which can actually give you measures? Definitely we don't have for every disease, but at least, say for example, for diabetes, we know we can wear sensors sending glucose data that could prove whether medication was taken or not, and also smart insulin pens and such. And also, do you think together with that, if we put reliable smartphone application at the fingertip of patients for patient-reported outcomes and adherence, do you see that as a possible solution to all the problems that we are talking about? And this question is to all presenters.
Caitriona.
Yeah, well, I do. I think if obviously I think the more information that can be measured and captured about a patient's medication taking behavior and their health outcomes, it's only going to increase knowledge and help us to measure adherence better and support patients better. And I suppose the key is what we're lacking still is trying to, why we've better methods now of collecting data and is trying to make use of that data in a meaningful way, in terms of actually measuring adherence and how actually best to do that.
Sorry, very quickly, what can we do so that governments and health insurance companies will actually take up these technological solutions, or buy these technological solutions, because solutions are there. In fact, my own company has a solution, but when you try to sell it, market it to the authorities, it's very difficult.
Yeah, well, I mean, I could speak from the Irish, our Irish perspective. We've a lot of problems in terms of using health data and patient data. There's a lot of regulations, and a lot of it requires individual patient consent. So I don't know if that's across the board. But I think that's something probably that needs to be overcome in terms of being able to access data and share data and to use data.
But if the patient is the owner and gives consent, then where is the problem?
Well, it's getting that on a large scale is probably the difficulty. Like there's a lot of small studies you'll see and they're all great studies, but I suppose it's trying to implement that on a large scale or at a population level.
So we should focus on study right now, larger studies.
Oh, both. Try and do it all.
Thank you.
Thanks. So Eva, do you want to pose some questions?
Yes, I was just thinking, because we are now looking into recruiting non-adherent or hard to reach patients and so on. And in your presentation, Enrica, you spoke about when you have like the non-initiation and discontinuation and so on, and you gave examples of why people are in this phase and so on. And I just had a blunt question with regard to how did you recruit those people to get those statements, or what is your well, I guess the methodology behind it?
Sorry, it's for me?
Yes.
Oh, thank you. So your question is how we understand in which phase is the patient?
Well, yes and no. I think it's more with regard to if the patient is in a non-initiation phase or a discontinuation phase. It's more how do you get those patients that that they are in. So it's, if they don't start taking the medication, how do you get them?
Yeah, well, it depends from the motivation. From if you, first of all, you have to understand if he's it's important to understand if he's an intentional or unintentional starting doses, and for example, to some solution to get information about non-initiation of prescription as described from Caitriona, between the link of the prescription and the dispensation. You can understand if patients that receive prescription don't go to the pharmacist to take the medication. So this can be a system of alert to detect patients that don't go to take the medication after the prescription. And then it's important to start to understand why patients don't take it, if they are not aware about the utility of the medication for them, or because they, yes, it's unintentional to don't start, they think that is not so useful in that moment, so they go back. But data can, for sure, data can help to detect some information. And the link between all healthcare professionals, the use of the patient record can help in the in building this kind of system to detect this information. And there are some initiatives, but these initiatives are usually at a local level, are just some pilot, and so there is a need to build up more evidence and to understand how to implement this experience in the routine clinical practice, because sometimes they are a success because there are the right situation, because it's a pilot, because people is at the beginning is encouraged to do something, but it's different if you have to implement this experience in the routine clinical practice. You need to understand how to implement them. If you need some incentives, if you need to more structure of data, but for sure, sharing data and sharing information can be an important starting point to start to detect most of the patient, not all, but most of the patient that need to be get on board and to follow up. I hope that this is
Thank you.
No, Eva, let me, Enrica, let me tell one thing, because Eva, I know exactly what you are asking for. And in fact, most of these works and the work that Enrica present has been developed using databases. And the first phase is more or less to identify between the difference between the time of prescription and the time of dispensing. Okay, of course, this has some kind of is not in fact something that we want to achieve, is to see exactly why the reason why a person don't take their medicines, they don't start the medicine. So we need to look for at least and to intervene or to see the reasons why people do not start. But in fact, most of these works are based in this difference between the time of prescription and the time of dispensing these medicines. Paco, to finish, is your time.
Thanks, thanks a lot. Thank you very much for the wonderful presentation. I have one question in relation to how to move from adherence to medications to adherence to treatment. So if we need to focus or to start exploring behaviors, what do you think are the key factors or the key issues that we should take into account? Thank you.
Yeah. For for me the question, thank you. Yes, this is a great question. As just recently in Italy, we performed a translation of the ABC taxonomy in the Italian languages, and one of the discussion was about the fact that it takes in account the adherence to medication, and currently many interventions are behavioral intervention or are some rehabilitation intervention, and so we discussed about this opportunity to dedicate and also the discussion about this kind of treatment, and not only to medication, as many chronic conditions needs the behavioral intervention and in rehabilitation intervention, and after the, so it is something that is currently under discussion, because it's a very important part of the treatment to include not only the medication, as many times behavioral intervention may have an important effect on the care of some patients. So it's something that really it's so thank you for this question, as it's a very important part currently under discussion.
So, any other question, or we can finalize the webinar?
Very quickly, Eliseo, since it's a behavior, could we use incentives to keep to adherence? Like, if you adhere to your treatment protocol and end up with better clinical results at the end of the year, your health insurance premium is reduced, or you get free medication, or things like that. Just a thought.
Yeah. Yeah, it also, this is a very hot topic, as from the review published from OECD report. There are some countries that use some fee to pay for intervention. In some countries, in Italy, it is not the case, but I think that in some countries, Caitriona, I don't know if in Ireland, but in UK, there are some intervention. Yeah,
it's a tricky area because it's very, it can be abused, and you know, I think it has to be very, I mean, carefully monitored and costed also. I mean, you want to make sure the benefits outweigh your costs. So yeah, I don't know, I'm not a big fan of incentives, but that's just my.
It's a double sword.
Yeah, it's a double-edged sword, exactly.
It's a double-edged sword. But looking at the cost of non-adherence, not just monetary, but non-monetary burden as well, and then what could be the possible cost of implementing something like this? Like I said, that's why I said it's just a thought. I think we should at least have this discussion as a possibility, and then looking at the results, we can decide. What do you think?
Yeah, I mean, I think so. And I think there's been some good work done in the UK, more so around incentives, but not so much in terms of, more in terms of kind of social incentives, in terms of getting, bringing people together, in terms of, you know, adopting healthier lifestyles and exercise programs and supporting each other, particularly in kind of lower socioeconomic groups. So, I mean, maybe something, a model like that could be more beneficial, and people may be more, you know, ethical and in the long run, and people may be more likely to maintain. Yeah, I mean, it's a really interesting area.
It could be non-monetary also, like
no, absolutely, and that's what some of these programs are. They're not monetary, but
like
they do give other social benefits to people, and so
that's something to that. I think the monetary incentive is a bit unethical. But if we're thinking about gamification as an incentive, that could work, but only if we understand the motivators for adherent behavior. And I think that's the key.
Yeah, no, absolutely. It's a minefield. It's interesting though, but
Okay, let's finish. So thanks to all of you for attending the webinar. Thanks to Enrica, thanks to Caitriona, thanks to Alpana. Was 3 great presentations and a great discussion. Please continue to follow the Beamer through our LinkedIn and Twitter accounts. And our next webinar will be in the 2nd of May, the 2nd of May at this time. And we will have in this 3rd webinar the opportunity to meet other projects on adherent film. So see you soon, and thanks again. So bye to
Thank you,
everybody.
everyone.
Okay.
Bye.
Thank you.
Okay.
Bye.
Right, right.
Eva, Louis.
Bye, thank you.